Professor Kübler, why is glucose management beneficial for critical ill patients in the intensive care unit?
Many patients treated in intensive care unit have abnormal high blood glucose level. We call it hyperglycemia. This hyperglycemia is deleterious for the organism. Many studies showed that it produces more infection, more sepsis, more surgical complication. Therefore, we have to treat it using insulin infusion. But this task is complicated.
Why do you say glucose management is a complex process?
It is complicated because we have not only to control high level of glucose, we must take into consideration low level, so-called hypoglycemia. It's also deleterious. And also very important is variability of glucose level during the treatment. So we have to treat 3 different metrics of glucose control.
Can our space glucose control help you in controlling this process?
Yes, we started with manual regulation of insulin infusion, and then we started with paper protocols and charts, and it was not precise. Therefore, we looked for another solution, and solution of decision support using a computer is this, in my opinion, very good solution. When we start this space glucose system, we have better results.
What are the major achievements you have since you are using the SGC system?
SGC improved glucose variability reduction. It is also very easy to handle, and it is very good accepted by nursing staff. So it makes glucose control easier and safer.
Thank you, Professor Kübler, for this statement.
This is Sherry Bosher reporting for Global Medical News Network.
There's new consensus emerging in the world of diabetes about easing up a little bit on the glycemic levels of hospitalized patients. Dr. Mary Korodkowski discussed this at the annual postgraduate course of the American Diabetes Association in San Francisco.
It was a consensus statement between the American Diabetes Association and the American Association of Clinical Endocrinologists to try to prevent a return to uncontrolled glucose levels in the hospital, which we know are associated with adverse outcomes such as infections, mortality, higher length of stay, cardiac arrhythmias, and to at least come up with a guideline for physicians who work in the hospital to use in caring for these patients. There's been a lot of variability in what's been published in the past several years. The study that brought this whole issue to attention recently was actually promoted a glycemic target of 80 to 110, which is lower than even what we try to aim for in our outpatient populations in many situations. Several subsequent studies since that original study showed that there is a hypoglycemia associated with aiming too low for those glycemic targets. And we don't really have the tools that help us safely get to such a low target in the hospital. Patients are ill, often they're anemic, often particularly patients in critical care units may have a low blood pressure or be on medications to maintain pressure. And all these things can affect the accuracy of what a blood glucose reading is when it's done with a bedside glucose meter. So we're probably not ready for those targets. The guidelines have been revised to try to aim more for a glucose of 140 to 180, which has been what's achieved in many of the conventionally treated groups in the studies that have been published. And at least there we know we are achieving a reasonable level of glycemic control where the risk for adverse effects associated with high blood glucose are minimized, but also the risk for a low blood sugar reaction is also minimized with a higher target range.
Reporting for the Global Medical News Network, I'm Sherry Bosher.
So Deborah, which difficulties do you have in glucose management for your kind of patients?
Our major burns patients are in a hypermetabolic state, so they have an increased demand for calories in their body, so we have to give them high calorie feeds which have a lot of sugar in them, send their blood sugars high. They also have multiple septic episodes, and in general, critically ill patients' blood sugars are high. In particular, our burns patients often require really high doses of insulin, and this has previously been difficult to control with our paper-based flowcharts and prescriptions, but with the spaced glycemic control system, that it's been very effective at managing those more challenging situations.
And what is the benefit of SGC for you and your patients?
We looked at 10 years of data looking at our glucose control in the unit, comparing 4 different systems that we've used. 3 were paper-based, 2 of which were prescription by doctors. 1 was a flow chart that it was nurse-led, the nurses decided on the dose, and the other one being the spaced glycemic control system. With the 3 paper-based methods, there was huge variances in the blood glucose results, with multiple hypoglycemic and hyperglycemic episodes. With the spaced glycemic control system, that hasn't happened. The glucose control is very stable, with no hypoglycemic episodes so far.
Was it difficult to change the culture in the ICU?
I think it was pretty easy from my point of view. The staff here are very receptive to change, including the nursing and the doctors. We have very good initial training from B. Braun, and anybody that was struggling along the line, we just clubbed together and helped those and gave those staff extra support with the system, and they soon picked it up. And once everybody learned to trust the algorithm, which was quite quickly in some cases, everybody really liked using it and used it effectively.
And finally, is SGC in general a device you would recommend?
A good experience with the spaced glycemic control system. It does exactly what it's supposed to do. It controls a patient's blood sugars very well. It's very effective at doing that. And it's a very safe system. I think especially like the system when you suspend the feed and it warns you that you're doing this and you need to think about turning the insulin pump off, which is in the past been a cause of hypoglycemic events, that there being a delay in turning the insulin pump off when suspending feed. So we like this safety feature, and it's definitely a system that we will use as part of our routine practice in our unit. And as far as we're concerned in this unit, we will continue to use the spaced glycemic control system as for our glucose control. Very difficult to go back to paper-based methods. The staff, when we had an episode where we weren't using it for a week, they were very keen to get it back. Found it very hard to go back to the paper-based method. So we really like it here.
Today we're going to be discussing the glycemic control portion of the Enhancing Patient Recovery Protocol. Glycemic control spans the preoperative, intraoperative, and postoperative periods and is a very important means of improving patient care. Evidence-based medicine suggests that hyperglycemia negatively impacts surgical outcomes. We know that patients who are hyperglycemic have impaired wound healing, they stay in the hospital longer, and so it's very important to keep sugars down. However, we also know that tight glycemic control can result in patient harm due to hypoglycemia. And so even though we talked a lot about tight glycemic control about 10 years ago, the goal of bringing sugars down to the 120 range really is not a great idea. And so current recommendations are to keep sugars in the 160-ish range when managing hyperglycemia in the perioperative period. We also know that some surgical patients are undiagnosed diabetics. We've published some of that literature here from Beaumont, that even though patients may not know they have diabetes, if they come in, their hemoglobin A1C may show that they indeed are diabetics, and so special attention should be paid to their sugars when they come in. Therefore, our recommendations are that all patients scheduled for colorectal surgery will have their hemoglobin A1C checked 3 days prior to surgery. That'll be when they come in for their type and screen. If their level is greater than 9, their operation will be canceled. That's been decided in conjunction with the surgical and endocrinology departments. If hemoglobin A1C is elevated in someone without a history of diabetes, so in other words, you have now a newly diagnosed diabetic in front of you, we will be checking glucose in the morning of surgery, just like we do with all of our diabetics. And we will treat them intraoperatively as we would a non-insulin dependent diabetes patient. We're not generating any new protocols. We will follow current Beaumont protocols, and we have to ensure that the surgical team is aware so that they can continue glycemic control postoperatively and get appropriate consultation at the time. If you have any questions, feel free to contact either myself, Rebecca Kelly, who is the Enhanced Recovery Project Manager, Dan Savasi, or Carol Schmidt.